I won't go over the features of the NICAS that have already been discussed by Dr. Soma, except just to point out that the basic measurement that's made is the measurement of resistance, which is based on the change in volume as the result of each heartbeat with a difference in volume, in the actual stroke volume. And that's the basis for that. And all the other measurements that it makes are derived from calculation, the stroke volume leading to the cardiac output, and with an accurate measure of blood pressure, measures of cardiac power and total peripheral resistance. Already, Dr. De Soma has also shown the validation by thermodilution studies, and these have been corroborated more recently because the thermodilution studies did not involve dialysis patients by a study with echocardiography done by Drs. Germain and Chait and colleagues in Amherst. And as you can see, the results look pretty good, R of 0.92 and very little bias in the Bland-Altman. Just to mention in passing, there are two further points to make about these measurements or these processes. The one is that there are thoracic devices that are used, bioimpedance devices, which are not accurate and have not been approved by the Food and Drug Administration in the United States. And secondly, the other measurement made by this device is the measurement of total body water. The device uses a frequency of 32 kilohertz, so it measures total body water.
Interesting.
I would like to discuss briefly a study that we have just completed of 54 patients done in the United States and half in Brazil, in which the device, the NICAS device, was used to characterize intradialytic hypotensive episodes. The study was done by comparing all the results with each intradialytic hypotensive episode that was observed with baseline studies. So that was the basis of the comparison of the actual study. And the definition of intradialytic hypertension, as you can see, was a pretty stringent one. It is one that's used frequently in the literature, but it's pretty stringent. Is a blood pressure reduction by greater than 20 millimeters of mercury, systolic blood pressure, or diastolic by greater than 10 millimeters of mercury. But what makes it stringent is that the intradialytic nadir is that the patient's blood pressure must have dropped to less than 100 millimeters of mercury. In addition, perhaps not of great interest, but certainly important, was the study of intradialytic hypertension, which was defined by a mean arterial pressure increase of greater than 15%, and again, an intradialytic nadir of greater than 100 millimeters of mercury. And what's very interesting, in both the Brazil and the United States studies, there were no significant differences in demographics and in the fluid removal between the patients who developed intradialytic hypertensive episodes and those who did not. I think very interesting, but making, to my mind, the study valuable because it excludes to a major extent the question of different kinds of disease in those who did and did not get hypertension. What I want to say by that is that a lot of what we're talking about is not related to the patient as such, but to the artificial degree of fluid removal, rate of fluid removal that we see so commonly, particularly in the United States, which defines the duration of the dialysis. And in other words, as you reduce the dialytic dialysis period, you can expect more intradialytic hypertensive episodes. Now, this very important concept, Cotter's ventricular arterial function curves, is of importance because it describes really what we've done and what we have found. So the relationship between blood pressure and cardiac output, and what we're looking at are several kinds of clinical situations. The one is decreased cardiac power. Sorry. I must have gone the wrong way. I apologize. Decreased cardiac power with decreased preload. On the other hand, increased cardiac power with increased preload, usually. That's the reason for the cardiac power being low and high. But, of course, you can see clearly that another major reason would be intrinsic ventricular disease. And then very important and somewhat newer for the study of dialysis patients is that of vasodilatation with a reduction in total peripheral resistance and an increase in total peripheral resistance causing vasoconstriction. So I'm not going to go into the details, obviously, there isn't time, but just to point out some of the general trends. Looking on the left side, the IDH due to cardiac power reduction, you can see those individual red arrows represent the findings of the patients. And what you see here is that the cardiac power is reduced. These two lines, the long lines, are the ones that are the levels of cardiac power. The lines that are diagonal at these here, just to make sure, these here are lines of peripheral resistance, these two lines, high and low. So what you see clearly here in this group of patients, IDH was reduced due to preload reduction without a significant change in TPRI. And then looking at the right-hand side, we see a different circumstance where IDH was due to TPRI, was due to CPI increase and no significant change in TPRI. And finally, I'm sorry, I have to go back. So that was what I said there. Then on the right-hand side is IDH due to vasodilatation, and all these arrows are representing now a reduction in peripheral resistance. And in the middle is IDH due to mixed hemodynamic, both together. And in these cases, there's no significant change in cardiac output. I also want to show you that in the group on the right with vasodilatation, there was no significant change in cardiac power. So to make it quite clear, changes in cardiac power, changes in peripheral resistance, and a combination of both are the kind of things we see in dialysis, and really for the first time, as far as I know, to clearly define what are the reasons, these heterogeneous reasons for intradialytic hypertension. In regard to intradialytic hypertension, I'm not going to go into the same detail here, but due to vasoconstriction, due to hyperdynamic state, or both together again. And I think we're all familiar, those who do dialysis, with these patients who become hypertensive during dialysis with increasing vasoconstriction, and those that have very high degrees of fluid overload and good hearts, and they are hypertensive from the start. So it's a problem with hypertension, of course, in dialysis, but far less of a problem than the ones who have hypotensive episodes. Example from a paper by Dr. Flythe and colleagues with slow IV refill due to high UFR in a patient with a reduction in circulating blood volume, and as a result, ischemia, myocardial stunning, and McIntyre's various reports not only of myocardial stunning but damage to the brain and to the gut as the result of these episodes of intradialytic hypertension that I'm referring to here. And in the heart, irreversible loss of muscle contractility, cardiac power reduces sharply, systolic function decreases, and a marked real effect on survival of patients. Now, just briefly, in those 54 patients that I described to you, it was interesting that you could divide the patients quite clearly, as I mentioned already, in those who had a CPI decrease, those that had a TPR decrease, and those who had both. And the number of patients, or the percentage of patients in each group, was more or less the same, about 35% in the CPI decrease, 37% in the vasodilatation decrease, and 27% in the combined group. And what was of interest was that there were more diabetic patients in those who had vasodilatation, which I think is very consistent with what we know about autonomic dysfunction in diabetics outside of dialysis, but in a patient with chronic kidney disease with diabetes. So, the important thing is, what does this do for us in terms of the future? And I believe what it does for the future is gives us what we can do to reduce the extent of intradialytic hypertension and to do something about it. So the ones on the purple figure on the left, these are the ones with vasoconstriction, with a high blood pressure during treatment. These will be patients who one has to, these are hypertension. We would reduce the target weight and perhaps use vasodilator drugs. In other words, just reduce the total blood volume. On the second group, the red one with the low CPI, these are ones who don't recover their blood pressures after weight reduction, and one has to be very careful with these people not to get them to a point of very severe hypertension. So we reduce the UFR by adding a fourth session and reduce IDW and reduce the IDWG by sodium restriction in some of them so as to reduce the necessity to remove fluid from the circulation. And these are patients who have to be handled carefully. In our country, prolonging the dialytic period would make all the difference. I think you do it much better in Italy and many European countries, longer dialysis times. Then the blue color on the right, these are the patients with high blood pressure and a blood pressure increase during treatment. And in these patients, decreasing the target weight and reducing IDWG are similar actions, but of course not to the same degree and not necessarily with the same degree of care as those who have low CPI as well. Sure. And finally, the ones that were somewhat of a surprise because of their frequency, relative frequency, are those patients who have a low TPRI with vasodilatation. And in these patients, lowering the dialysate temperature, an old action which was not really recognized as to what extent it was changing the peripheral resistance, and otherwise the use of adrenergic agents such as midodrine makes a difference to these patients. So we have therefore the possibility of improving, very much improving, or partially preventing perhaps intradialytic hypertensive episodes. And overall then, we're looking at the cardiac power, we're looking at the peripheral resistance, and these can be adjusted for, as I've mentioned before, by a number of relatively simple and yet relatively effective agents and processes. But what we need, of course, are outcome studies. It's going to take some time before we know to what extent we can actually achieve what seems likely by reversing the pathophysiology that has been demonstrated. So I'm not going to go into this now, but just to point out again to you that we're dealing with high blood pressure, high TPR, high blood pressure, high CPI, low blood pressure, low CPI, and low BP and low TPR. So we have approaches to all of these. I'm looking to see other people adopt these, test them, to see whether in fact we can make a change into what is a major difficulty in many dialysis patients. To summarize then, blood pressure is an important vital sign but doesn't provide the information we needed. We need to characterize intradialytic hypertensive or hypertensive episodes. And these new measurements provide the information that it enables action, and we'll have to see whether interventions based on hemodynamic profiles in the long run is going to make a difference to how we conduct dialysis. Thank you very much.